go to the first speaker. And the first speaker is Sorcha Dhubhghaill, a brilliant scientist from Belgium, actually, who will discuss cataract surgery in Magalocornea. She was recently elected as an ECRS board member. Let's watch the video of Sorcha.
Thank you so much to the SOE for giving me the opportunity to present at this webinar. My name is Sorcha Dhubhghaill. I'm one of the corneal surgeons. I'm a board member of the ESCRS, and I'm also on the EBO, and I'm a proud holder of the FEBOSCR accreditation. So what I want to talk about today is a very tricky case for cataract surgery. We'll start off with a young patient, 36, that's very young for a cataract, and his vision is slowly getting worse. But he's known with a rare ocular condition called X-linked megalocornea or mega anterior chamber. So this guy has a huge anterior chamber, but a relatively normal posterior chamber. By stretching out all of this tissue to make it larger, this results in a relatively thin cornea, an atrophic iris. They tend to get pigment dispersion, and they can form a Krukenberg spindle. But from our point of view, the difficulty is they get early onset PSCC. When you see this patient in the waiting room, you're going to notice it. He's staring across the hallway, looking at you with these very large and quite interesting looking eyes. He's not the only one in his family with this. It's X-linked, so his father and his nephew also have similar appearances. So when we look at him at the slit lamp, you're really going to see the features of X-linked anterior megalophthalmos. Large corneas, and you see in the lower images here, the iris looks almost flat. It's like a sort of stretched out trampoline, and the cornea is relatively thin. Why is this a problem? Well, we're going to do this cataract surgery, and if we fail to reach our target, we have very little options to correct. This is very difficult to fit a contact lens on these people. The cornea itself is very thin, so laser corrective or sulcus lenses are not that helpful. Why? Because if you measure the white to white for this patient, it's 15.2. So your average sulcus lens will in fact be too small, so you can't put an ICL in these patients. So what you want to do, as we always do, you want to get it right first time. So let's look at the further diagnostic tests. On pentacam Scheimpflug imaging, you see it's a relatively flat cornea because it's so big. The anterior chamber depth is 6.3, almost 7 in some areas. That is a very deep eye. And his cornea on the right side is 411. So very little room for error if you need to do a refractive correction. So refractive corrections in the cornea and in the sulcus, it's not going to work. So if we look at his biometry, the right eye lens star biometry suggests that we want to put in a lens power of 12.5. I'll immediately tell you that this patient needed a lens power of 15. So this biometry is very way off. But I will draw you to one aspect on the biometry. His axial length is 27.4. 27.4 sounds like a myope. But remember, his anterior chamber depth is almost 7. So 7 of those millimeters are in the front, making his posterior segment almost normal. How does this influence our lens surgery? Well, it all comes down to effective lens position. Effective lens position is one of the most important aspects that determine what lens power you need. In most people, the effective lens position is more or less 1/6 of the axial length front to back. Because the front of his eye is so large, it's further back, relatively speaking, and it's at about 1/3 of the distance between the cornea and the retina. As a result, we have to adapt his IOL calculations. And we know this beforehand. We don't want to have a refractive surprise. So we realize, okay, the power's got to be different. How can we do that? Well, we used the IOL calculation using paraxial matrix optics as described by Wolfgang Hages. The reference is here. And it utilizes a ray tracing approach, which is much, much more accurate in the context of these cases. Your standard IOL formulas are not going to fit this non-standard eye. So now we know what powers we want to go for. But let's think about what lens type. If we use a standard lens in the bag is huge. The lens is just going to sun down into the lower part of the capsular bag, and you're going to have a patient that's seeing out the edge of the IOL. So what are the options here? The sulcus is very big, so sulcus lenses, add-ons, it's not that easy to find the right lens. So if you look in the literature, there is a family of these patients that's been followed up over the years, and that's reported by the group of Harminder Dua. And what they did was avoid the bag problem entirely by putting in anterior chamber IOLs. They would clip the iris claw onto the iris, and this would give a reasonable visual correction because it doesn't matter what size the bag is, the lens is right over the pupil. The problem is that flat featureless iris, they tend to erode, and over time, the lenses can cause further holes and they can luxate and drop out of position. So for this patient, we picked a completely different option, which is the bag-in lens. The bag-in lens has been sort of replicated by the Femtis lens, but the idea is you forget about the diameter of the bag, you create your own capsular rhexis that holds the lens in its place. But what do I mean by that? Let me show you a little video to describe how the concept works. So like any lens implant, we're going to start with an anterior rhexis, but this is going to hold our lens. So we have to be very specific about how we make that anterior rhexis. It's got to be 5 millimeters in size. So for this purpose, we tend to use a ring. You can use a projection of the microscope, but or you can use something like a femtosecond laser or a guided laser. Personally, I just use a small little ring. In addition to the anterior rhexis, we also make a posterior rhexis. We're making 2 matching holes. This is a primary posterior rhexis, which if done correctly has the same risks as a non-posterior rhexis. And using these 2 holes, we pop the IOL in like a button. So the lens is supported by the opening that we made and not by any inherent properties of the capsule. So what did that look like? Well, here's the surgery of this patient, utilizing what we knew in advance, utilizing a 15 diopter lens instead of a 12.5, and using the bag-in lens. So we ultimately published this. So the first thing you're going to see is that the eye is very big. I performed the surgery under general anesthesia. It's a complex case, but I also find that younger patients prefer general anesthesia. They're a little bit less brave than our older patients. I use 2 paracentesis because I want to be quite careful in doing my irrigation aspiration. What happened here is that I used a dispersive OVD and 1 was not enough. I had to use a second dispersive OVD because the volume of the anterior chamber was so big. Now I'm making a 2.8 diameter, 2.8 incision, and it looks tiny. And here is the ring I was talking about. That's going to give us the 5 millimeter shape that we want to fit our bag-in lens in. In a normal or a typical patient, this looks like a very big ring, but relative to this patient's entire size of their eye, it looks pretty small, but this is a 5 millimeter diameter ring, and we make our anterior rhexis in it. He's younger, and it's predominantly a PSCC, so taking the lens out is not that difficult. It's quite a soft lens, but what you have to know in these patients is that they can have relatively loose zonulae. They've had some pigment dispersion, and their capsular bag can show some instability. Be careful when you're considering a capsular tension ring in these patients. You need to go for a very large size, otherwise it will exhibit no tension at all. In this case, it wasn't necessary, so we cleaned out a little bit of the space there. I don't remove every single piece of cellular material in the periphery. Why? Because it will seal in my lens better. Now I'm making a posterior rhexis with helon behind the lens, and we're matching that in the same size so that it'll accept our IOL. I inject the IOL in, I hold a little second instrument behind it to control where it goes. And now we just pop the lens in through the anterior and posterior rhexis, and it captures the lens to center it. So it doesn't matter that the haptics are not all the way out to the edge, because the bag itself will hold it in place. Now, most of the time I don't need to suture patients, but this patient continued to leak because the cornea was quite soft. And then I tried to put a mega soft contact lens on, still didn't fit. So I sutured every incision here to ensure that the wound had good integrity. So at the end of the case, we use myostat to protect the IOL and keep it from incarcerating, and it worked out quite well. So what did I see down in the clinic? Down in the clinic, I was pretty happy. The lens appeared very well and centered. The patient sees 16 on 10 unassisted. And if you see on the right there, that I was pretty happy with my refractive outcome. But remember, had I followed the typical rules, I would have come nowhere near this. So the take-home message is you have to understand the normal situation so that you could adapt for outliers. You have to think about your effective lens position and how abnormalities in the biometry can change that. So I want to thank you for your attention. I want to thank the SOE for giving me the opportunity to present. If you have any questions, you can email me here at this address. And I want to thank the research groups that I'm affiliated with in USA, Argos Research for Ocular Science, the University of Antwerp, and the Visual Optics Lab of Antwerp, Volantis, because I didn't do this all on my own. I had the help of some wonderful biologists and physicists to crack this case. Thank you so much.
Thank you very much, Sorcha, for this wonderful presentation. And I think that this is really a very beautiful example of what we consider something that is really something special, something so special that it is worthwhile to speak about, because I think indeed you have not so much choices of intraocular lenses. Now, one question maybe that I would like to ask you, and that is, this case typically belongs to outliers, isn't it? And we still have the problems to define the outliers. Do you have other ideas how to solve these options, how to take care of those patients? Because these are the ones that will always be a little bit more too hyperopic or too myopic or whatever. And that is, of course, something that I know that in Antwerp, we are very sensitive to that, and we would like to find a solution on that. So
yeah, I mean, I think in the realms of cataract surgery, we're almost victims of our own success, because every patient has a neighbor or friend who had a perfect cataract surgery. I think the most important thing is to know beforehand that you have an outlier. We want to be efficient, we want to work quickly, but we can't trust always the data that comes back, because the data is not capable to say, hold on a second, triple check this, or at least it's not available yet. What's really important is that we as ophthalmologists don't delegate the thinking to the machines. Understanding, and I think it's most important, the concept of effective lens position is key for young ophthalmologists, because the effective lens position is a mystery. It's a prediction of what your lens will ultimately achieve or what space it will sit in. And what I like about this case is that actually, technically speaking, we did all the steps as we normally would. We just had to think more about effective lens position. Until now, there's no perfect one-size-fits-all formula to do the work for us. So we still need to do the work ourselves. It's not wrong to tell a patient, oh, hold on a second, you have a very large eye, which we will see more in future, or you have a very small eye. I'm going to need more time to consult and to determine what the best option for you is. That's allowed. We don't have to immediately have all the answers personally. It's recognizing it that we have to do.
exactly. I think you're absolutely right, recognizing that the patient is an outlier. And I think that this is the big message of your talk. And I would like to thank you very much for this presentation.